Hello everybody and welcome to our module on pulmonary circulation. Let's start by talking about the pressure in the pulmonary circulation. You should know that the pulmonary circulation is a low pressure system, much lower than what you find in the arteries of the body. For example, as you know, a normal systemic blood pressure is about 120 over 80. In contrast, a normal pulmonary artery pressure is about 24 over 12. For this reason, the walls of the pulmonary arteries are very thin relative to arteries on the systemic side of the body. They have less smooth muscle. They have less resistance to flow, and they are very distensible, meaning they are very compliant. This also has implications in our heart. As you know, the left ventricle is much thicker than the right ventricle, and that's because the right ventricle only needs to generate pressures like 24 over 12. It doesn't need to have enough muscular strength to generate high pressures like 120 over 80. The pulmonary circulation responds differently to changes in blood oxygen content from the systemic circulation. In the systemic circulation, if there's a low oxygen level, a low PaO2, this is going to cause vasodilation of blood vessels, and the idea here is that tissues want to increase blood flow to bring more oxygen in when they sense that there is hypoxia. In the lungs, it's the opposite. When there's a low oxygen level, this leads to vasoconstriction. Low oxygen levels are directly sensed by smooth muscle found in the pulmonary vessels, and this cuts off blood flow. This is called hypoxic vasoconstriction. And the idea here is that our body has evolved so that blood is shunted away from poorly ventilated areas. This allows more blood flow to go to the well-ventilated areas. And where this is very important is during fetal development. In the fetal circulation, there's relatively low oxygen content, and that constricts the pulmonary arteries in the womb. This allows the blood to circulate to other organs that are growing and not grow through the lungs, which aren't providing any oxygen when the baby is in the womb. After the baby is born, the pulmonary arteries and blood vessels begin to receive more oxygen, and then they dilate, and then we get more blood flow through the lungs. So if you were to graph the oxygen content of blood on the x-axis and the blood flow on the y-axis, for the lungs it would look like this blue line here. As the PaO2 goes up, there's more blood flow. In the systemic circulation, it's the opposite. As the PaO2 goes up, there's less blood flow, and when the PaO2 falls, that's when those vessels dilate to really increase the blood flow. Now let's do a brief review of gas exchange as blood moves through the lungs. Shown on this slide is a pulmonary capillary in red with blood flowing from left to right. It flows past an alveolus, shown in blue, with oxygen coming into the blood and carbon dioxide leaving. The gas content of the air that we inspire if we're at sea level breathing normal 21% oxygen air is 150 millimeters for partial pressure of oxygen, and there's essentially no carbon dioxide in the inspired air of our atmosphere. Once air gets to the alveolus, the concentration changes. Carbon dioxide is added, and the carbon dioxide partial pressure goes up to 40. And oxygen is removed and it mixes with carbon dioxide, and the oxygen content falls to 100. Blood coming into pulmonary capillaries comes from our venous system. It has a very low concentration of oxygen because oxygen has been consumed for metabolism by tissues. So the partial pressure of oxygen in venous blood is about 40 under normal circumstances. The carbon dioxide content is relatively high. It's usually about 46. That's because carbon dioxide is produced by metabolism. And then the blood moves through the pulmonary capillary, exchanges gas with the alveoli, and when it leaves, a normal partial pressure in the artery for oxygen is about 90, and a normal partial pressure for carbon dioxide is about 40. And this difference of 90 in the arteries compared to 100 in the alveoli is called the AA gradient, and I talk about that in detail in the video on hypoxia. So now that we understand that, we can talk about how gases are exchanged between the alveoli and the bloodstream. So gases like oxygen or carbon dioxide can be classified by the limiting factor for gas transfer within the body. To understand this, let's look at the bottom right side of the screen. So imagine that we have carbon dioxide found in venous blood. That venous blood is delivered to the lungs. This is perfusion of the lungs. Once the blood gets to the lungs, carbon dioxide has to diffuse out of the blood into the alveoli and establish equilibrium with the alveoli. Well, if the limiting factor is the blood flow delivered to the lungs, the perfusion, then we say that gas is perfusion limited. This means that the more blood flow we have, the more gas we will transfer, and that the total amount of gas that is transported depends on perfusion. More blood flow leads to more uptake of gas if gas exchange is perfusion limited. On the other hand, if the diffusion of gas out of the bloodstream into the alveoli or vice versa is what limits the total amount of uptake of gas, then we say that that gas is diffusion limited. And this means that gas transport, the total amount of gas going in or out of the bloodstream, is limited by diffusion, not by perfusion. To understand this better, let's look at this graph I've drawn on the screen here. Along the x-axis is the length along the pulmonary capillary as blood moves from the venous side of pulmonary capillaries over to the arterial side, where blood is exiting the pulmonary capillaries, heading into the left atrium and the arteries. Along the y-axis, I've shown the partial pressure of gas, basically the concentration of gas in blood. So what I want you to do is imagine that we administer nitrous oxide to a patient. Normally there's no nitrous oxide found in our lungs or in our bloodstream, but we're going to administer nitrous oxide to a patient to do an experiment. So what we're going to do is administer nitrous oxide and establish an alveolar concentration of nitrous oxide of P sub A right here. So inside our alveoli, nitrous oxide will be at this concentration. And now we're going to examine how the concentration of nitrous oxide changes as blood flows along the pulmonary capillary and picks up nitrous oxide from the alveoli. And if we were to do this experiment, we would find a curve that looks like this. So initially, venous blood enters the pulmonary capillaries with no nitrous oxide because we don't normally have any in our bloodstream. But as blood flows along the pulmonary capillary, it picks up nitrous oxide from the alveoli and it quickly reaches equilibrium where the concentration in the blood, which is the blue line here, is equal to the concentration in the alveoli. And when a gas behaves like this, we say it is perfusion limited. And nitrous oxide is the classic example of a perfusion limited gas. And you can establish this experimentally by looking at how quickly the concentration rises as blood flows through a capillary. If we were to do the same experiment, but instead of nitrous oxide, we administered carbon monoxide, we would find a curve that looks like this. So once again, we don't normally have any carbon monoxide in our bloodstream, so the venous blood would enter the capillary with zero carbon monoxide content. But as it moved along the capillary, it would pick up carbon monoxide from the alveoli, but it would never reach equilibrium with the alveoli. Gases that behave like this are said to be diffusion limited. Because diffusion is limiting the gas uptake, it can never reach equilibrium with the alveoli. That's the hallmark of a diffusion limited gas. And carbon monoxide is the classic example of a diffusion limited gas. So it's nice to know that nitrous oxide is perfusion limited and carbon monoxide is diffusion limited, but what about oxygen, a gas that is very important to our body? Well, first of all, when the venous blood enters pulmonary capillaries, the concentration of oxygen is about 40 millimeters of mercury. It is not zero like for carbon monoxide or nitrous oxide because we always have some oxygen in our blood, even in the venous system. In a healthy person at sea level, the alveolar concentration of oxygen is about 100 millimeters of mercury. And if we were to look at how oxygen content changes as blood moves along a pulmonary capillary, we would get a curve that looks like this. So oxygen does reach equilibrium with the alveoli, and that means that in healthy lungs, oxygen is perfusion limited. There are, however, pathologic processes which impair the uptake of oxygen, and when that happens, we can get something that looks like this. For example, pulmonary fibrosis impairs diffusion of oxygen into the bloodstream. So in patients with pulmonary fibrosis, they can develop hypoxemia. And this happens because oxygen switches from being perfusion limited to being diffusion limited, and therefore it never equilibrates with the alveoli, and the partial pressure of oxygen when it leaves the lungs, in other words, when it leaves the pulmonary capillaries, will not be 100, it will be some value lower than that, and that represents hypoxemia. If a person ascends to high altitude, the atmospheric pressure of oxygen is much lower, and therefore the partial pressure of oxygen in the alveoli is much lower. It can get as low as 60 if you climb to certain heights. When this happens, oxygen transfer into the lungs is still perfusion limited. However, the highest it can get is 60, that value in the alveoli, and therefore we develop hypoxemia, not because of any shift from perfusion to diffusion limited gas transfer, but because the atmospheric oxygen content becomes lower and therefore the alveolar oxygen content becomes lower. And shown here is the curve for carbon dioxide. So carbon dioxide in the venous blood, which is entering pulmonary capillaries, is usually about 46 or so. It depends on the metabolic activity going on. As blood moves along the pulmonary capillary, it releases carbon dioxide and therefore the level falls and it equilibrates with the alveoli, and therefore carbon dioxide, just like oxygen, is also normally perfusion limited in terms of gas exchange. In clinical practice among patients with lung disease, the DLCO is commonly measured. The DLCO is the diffusing capacity of carbon monoxide. This is a measurement of the ability of the lungs to transfer gas. The way this test is done is the patient inhales a small amount of carbon monoxide. You may know that carbon monoxide is dangerous, but the amounts used in this test are very small and not dangerous. Because carbon monoxide uptake is diffusion limited, the amount taken up by the lungs is equal to the diffusing capacity of the lungs. So the patient inhales carbon monoxide, then exhales gas from the lungs, and the machine measures the amount of carbon monoxide exhaled. Patients who have lung disease that results in a significant impairment of diffusion will not take up much carbon monoxide. On the other hand, healthy lungs will take up more carbon monoxide. There are normal amounts predicted for age and body size, and a normal result is about 75 to 140% of the predicted value. Patients who have severe forms of lung disease that impair diffusion can have values like less than 40% predicted. In the video on hypoxia, I talked about how diffusion impairment can lead to hypoxemia in the blood. And I went into great detail talking about how the volume of gas taken up by the blood is proportional to the area for uptake of gas times the difference in partial pressures divided by the thickness. I won't go into all that now, but I will point out here that there are some classic disorders which have a low DLCO value. Those disorders are all associated with diffusion impairment. So patients who have emphysema have destruction of their alveoli and they lose surface area, and therefore the amount of gas that they can uptake by diffusion is limited. Patients who have fibrosis or pulmonary edema develop thickening of the walls of the alveoli, and this also limits the diffusion of gas. So in all of these disorders, emphysema, fibrosis, or pulmonary edema, the DLCO is going to be low, and the reason it's going to be low is because the test uses carbon monoxide, and the uptake of carbon monoxide by the lungs is diffusion limited. Let's talk about the resistance to blood flow as blood moves through the lungs. This is referred to as the pulmonary vascular resistance. In terms of resistance to blood flow, there are basically two types of vessels. There are alveolar vessels, which are the capillaries that surround the alveoli, and then there are extra-alveolar vessels, which are the arteries and veins that supply blood to the alveolar capillaries. Just like my drawing on the screen here, an alveolar vessel, which is a capillary, supplied by an artery and drained by a vein. When the volumes in the lungs and the alveoli increase, it has different effects on the alveolar and extra-alveolar vessels. Higher lung volumes tend to crush the alveolar vessels, and this causes them to have high resistance. Basically, they're smushed so that their diameter becomes very small, and this causes a lot of resistance to flow. However, at higher vessels, the extra-alveolar vessels, like the arteries and veins, are pulled open, so they actually have lower resistance at higher lung volumes. And this is just a quirk of our pulmonary system. The capillaries tend to want to have less air, and the arteries and the veins tend to want to have more air. The two can't both be happy, so our resistance goes up and down as air comes in and out during the respiratory cycle. And it turns out that if you plot the pulmonary vascular resistance, the resistance to blood flow during the respiratory cycle, you find that it is at its minimum at the FRC. So once again, the FRC is a very, very important capacity in our lungs. I talk about this quite a bit in the video on pulmonary physiology. It's a point where the tendency of the airways to collapse is perfectly balanced by the tendency of the chest wall to expand. And it's also the point during the respiratory cycle where the pulmonary vascular resistance is lowest. For the rest of this video, I'm going to talk about pulmonary hypertension. So the normal pulmonary artery pressure, as I mentioned earlier, is about 24/12, with a mean pressure of around 10 to 14. The definition of pulmonary hypertension is a mean pulmonary artery pressure greater than 25 millimeters of mercury. And for step 1 of your exam, one of the most important things to know is that the classic physical exam finding of a patient with pulmonary hypertension is a loud P2, meaning a loud pulmonary component of the second heart sound. They may say the patient has a loud P2, they may just say the patient has an accentuated or loud second heart sound. It's classically heard best at the left upper sternal border, and so if you read a description of any of these things, they are trying to tell you that the patient has pulmonary hypertension.